Hey there, class. Welcome back to the winter term. I hope you all had a wonderful holiday season and happy 2026. Last term, you built a strong foundation in ICD-10-CM diagnostic coding. You learned all about how to code conditions across the body systems, applying the official coding guidelines and more, moving from the index to the tabular list to select the most accurate diagnostic code. Now we're going to take the next step, procedural coding. This term focuses on ICD-10-PCS, the coding system used to report inpatient hospital procedures. PCS is different from ICD-10-CM in both structure and workflow. In ICD-10-CM, you typically start in the index and confirm the code in the tabular. In ICD-10-PCS, you build the code. You select the values from the tables based on the documentation and coding conventions. You will learn new terminology and a new way of thinking. Excuse me. PCS requires you to clearly identify the root operation, what the provider did, the body system and the body part, the approach, how they got there, any device left in place, and lastly, a qualifier if that is applicable. By the end of this term, you'll be able to break down an operative report, translate the language into PCS concepts, and construct a complete 7-character code with accuracy and with confidence. And like with ICD-10-CM, you want to expect that learning curve and give yourself some grace and give yourself time to learn this new system. This is normal. It's going to take time and practice. PCS becomes much easier once you master the logic and practice the table process. We will take it step by step, and you will get plenty of repetition and opportunities to practice in McGraw-Hill with your weekly assignments. So the learning outcomes with Chapter 33 include the following. You will be able to explain the purpose of ICD-10-PCS codes, why it exists, what it's used for, specifically how it captures inpatient hospital procedures in a standardized way for reporting, reimbursement, and data tracking. You're also going to be able to describe the structure of ICD-10-PCS codes. PCS codes are built, not memorized, so you're not going to be expected to memorize any codes, nor will you're never expected to memorize codes. In fact, it's totally frowned upon because they change so frequently, and there's so much involved with the code selection process. Each character has a specific meaning, and we're going to select the values based on the objective details of the procedure documented in the record. We will practice how to use the ICD-10-PCS alphabetic index and the tables right from the get-go, right out of the starting gate. The index helps you locate a starting point, but the tables are where the code is constructed and verified. If it is not confirmed in the table, it is not a valid PCS code. Next, we're going to cover general PCS conventions, things like how to interpret terms, how to apply definitions, and how to use the tables consistently. This is where PCS starts to feel more logical and less overwhelming because the same rules repeat across the body systems. Lastly, we're going to focus on determining the principal ICD-10-PCS procedure code and sequencing when more than one procedure is performed. The goal is to code completely and accurately, then sequence codes in a way that reflects what was done and what mattered most during the encounter. As we go along, I want you to keep asking yourself one question. What exactly was the objective procedure performed? PCS rewards precise documentation with clear logical thinking. Before we start building the PCS codes, we need to lock in a few key terms. And as we did with ICD-10-CM, we had those key terms. So nothing's going to change from that perspective. What I recommended that you do last term is still going to hold with this term. These key terms: create index cards. Create index cards. Create a way that you can learn the terms, learn the definition, and learn the matching term. It's imperative that you understand these terms when you assign those PCS codes. The approach is how the provider physically gets to the site of the procedure. This is not the technique, this is not the tool, it is the route. Think of options like open, percutaneous endoscopic, via natural opening, and so on. A big coding mistake is choosing the approach based on what sounds right instead of what the documentation supports. So again, you want to make sure that you code according to the documentation. If it wasn't documented, it wasn't done. So make sure that you don't look for a code based on, again, what sounds correct. The axis of classification is the PCS concept that each character position in the code represents a specific category of information. In other words, PCS is organized around axes. Each axis answers a specific question. We have section, body system, root operation, body part, approach, device, and qualifier. The body part is a specific anatomical site where the procedure is performed. PCS can get very specific here, so we have to pay close attention to laterality, the exact level or segment, and whether the documentation supports a more detailed body part. Body system is the broader category the body part belongs to. So in PCS, selecting the correct body system matters because it determines which table you're going to use. If you start in the wrong body system, the code is going to fall apart. It's just not going to work. So you have to make sure that you start in the correct body system. Device is something that's left in the body at the end of the procedure. It's important that if it's removed before the case is over, it is not coded as a device in PCS. Some examples include grafts, stents, internal fixation devices, drainage devices, only if they remain. So a device would also include an implant. So if you have a joint implant, or if you have a device left in for a cardiac procedure, pacemaker, for example, that would be a device. Qualifier is a final character in many PCS codes, and it adds extra specificity when needed. Sometimes it identifies things like the destination of a bypass, the type of transplant, or another detail that completes the meaning of the code. If the qualifier value is Z, that usually means it's no qualifier, but we only choose it after confirming in the table. Finally, root operation term is the heart of PCS. Root operation is the foundation. It describes the objective of the procedure. What was the procedure trying to accomplish? This is not the same as the procedure named in the note. Our job is to translate that documentation into a correct procedure definition. As we move forward, you're going to hear me repeat this. PCS is not about memorizing procedure names. It is about using definitions to build the code from the documentation. Now we're going to move into 33.1, where we focus on the purpose of ICD-10-PCS. This is where we answer why. Why? Why does it exist? What was it designed to capture? And why does it look so different from other coding systems you may be used to, such as ICD-10-CM? ICD-10-PCS was created to provide a standardized, detailed way to report inpatient procedures. The goal is consistency. When procedures are coded using PCS, the code communicates key factors about what was done in a format that is the same across facilities and across the country. PCS supports several major needs in healthcare. It supports reimbursement because inpatient procedure reporting contributes to how hospital cases are grouped and paid. It also supports data tracking and analysis because procedure codes feed quality measures, utilization reporting, and research. It supports clear clinical communication because each character in the code has a defined meaning. This meaning reduces ambiguity when the code is built correctly. So what I want you to remember from this section is that PCS is designed to be logical and expandable. New technology and new procedures emerge all the time. And PCS was built so codes can be created based on the definitions and the values, rather than relying on constant narrative code descriptions. As we know, healthcare is changing at a rapid rate. We're embracing AI in our daily life now. We're embracing new procedures, new codes, new diagnosis daily. So we have to have that ability to expand, and ICD-10-PCS allows that expansion. So as we continue, everything that we do will tie back to this purpose. Read the documentation, identify the objective of the procedure, then build a PCS code that accurately reflects exactly what happened during that inpatient stay. ICD-10-PCS stands for the International Classification of Diseases 10th Revision Procedure Coding System. When you hear PCS, I want you to immediately think of inpatient procedures. PCS is the code set used to report procedures, services, and treatments for patients who have been admitted to an inpatient setting. This is one of the most important distinctions in coding. ICD-10-CM is diagnostic coding. ICD-10-PCS is inpatient procedures. And we're not even getting into CPT coding. That's in the spring, right? CPT is a completely different system. So right now we're going to focus on PCS. PCS is not used for physician professional billing such as in the outpatient world, and that is in CPT coding. This slide lists examples of inpatient type settings where PCS reporting applies. We usually associate PCS with acute care hospitals, but you're also going to see those procedures seen in SNFs, skilled nursing facilities, or LTC, long-term care, as well as short-term care facilities. The key takeaway is this: if the patient is formally admitted as an inpatient and procedures are performed, PCS is how the facility captures the procedures in a standardized and a detailed way. This affects data reporting, quality reporting, and reimbursement. As we go through this chapter, keep grounding yourself in that purpose. PCS exists to describe procedures with precision. What was done, where it was done, how it was done, and was anything left in place. PCS codes are always 7 characters. So lucky sevens. Think of 7. Whenever you think of a PCS code, think of number 7. There are no decimals. There are no categories and subcategories like ICD-10-CM. Instead, PCS is constructed using a consistent framework where each character represents a specific piece of information about the procedure. The most important mindset shift here is this: PCS is not about looking up a code and copying it. It's about building a code from the documentation so you have building blocks. This means we have to read the record, identify the objective of the procedure, and then select values for each character position based on the PCS definition. As we proceed through these slides, you're going to see exactly what each character position represents. Things like section, body system, root operation, body part, approach device, and qualifier. So one of the first rules of ICD-10-PCS is simple, but it drives everything. And that every PCS code is exactly 7 characters. Not 6, not 5, always that 7. If you do not have 7 characters, there's something wrong, and it's not a valid PCS code. PCS codes are also alphanumeric, which means each character position can be a number or a letter. That matters because we're not counting digits like we sometimes do with ICD-10-CM. We're selecting values from a defined list, and those values may be numeric or alphabetic depending on that table. This is also where I want you to start thinking in terms of character positions. In PCS, the meaning comes from where the character sits. A value does not mean anything by itself unless it is the correct position in the code. So a takeaway for this slide is PCS codes are always 7 characters. They are built using both letters and numbers. And as we keep going, we're going to break down what each of those 7 character positions represents and how to choose those codes. Here's a quick PCS rule that will save you some time and prevent errors. In ICD-10-PCS, codes can use letters and numbers, but PCS does not use a letter O and I anywhere. The reason is simple. The letter O looks too much like 0, and the letter I too much like number 1. PCS eliminates those 2 letters to reduce confusion and improve accuracy, especially when codes are typed, read quickly, or copied between systems. So if ever you see a PCS code that includes an O or an I, that's a red flag. That's wrong. There's something wonky about that code. It's either not a valid PCS code or there is a typo. This is one of those small things that can add up to a big difference when catching the specificity and accuracy with ICD-10-PCS. This slide is the PCS map, if you will. It has 7 characters, and each position answers a specific question. If you know what each position represents, you can build codes consistently. So for number 1, character 1 is the section. This tells us which part of the PCS code set we are using. For most inpatient procedures you will code in the course, we're using medical and surgical section. Choosing the correct section matters because it determines the overall rules and the tables you'll be using. One moment. My nose is running. Excuse me. Character 2 is the body system. This identifies the general body system where the procedure was performed, like gastroenterology, cardiovascular, musculoskeletal, and so forth. The body system is what gets you into the correct PCS table family. Character 3 is the root operation. This is the most important decision in PCS coding. The root operation tells the objective of the procedure, what the provider intended to accomplish. This is not the procedure title from the op note. So if you look at the op note and say, "Oh, well, this is the procedure, I'm good." No. You need to read the operative note to determine what best matches that root operation in the op note. And you're going to learn all about it. You're going to have the opportunity to practice throughout the course. Character 4 is the body part. This narrows the procedure down into specific anatomical site. This is where details like the exact structure, level, segment, or laterality may come into play depending on the table. Character 5 is the approach. This tells how the provider accessed the site. Was this an open? Was this a percutaneous endoscopic, via natural opening, and so forth? This approach must be supported by the documentation. So you're going to, again, look at that documentation in the operative report. and it's based on the access route, not the device or the technique. Character 6 is the device. This is only used when applicable. Not every procedure has a device. It identifies a device that remains in the body at the end of the procedure. If nothing is left in place, the device value is typically a Z for no device. But we always verify that in the table. Character 7 is the qualifier. This is also used when applicable. It adds extra layer of detail that completes the code's meaning, such as the destination site, a type, or other specific information. If the table indicates no qualifier, the value will often be Z. So next I want to show you what PCS coding looks like when we actually build the code character by character. The example here is a laparoscopic bypass in the left upper extremity. Specifically bypassing from one upper vein to another using an autologous tissue substitute. So that's a word that you are going to start adding to your language, and that's autologous. This is exactly how you should think in PCS. We translate the narrative description into the 7 characters. Character 1 is a section, and in this case it's 0, which means medical and surgical. This tells us that we are in the most common PCS section for inpatient procedures. Character 2 is the body system. Here it is 5, which is the upper veins. That places the procedure into the correct table family for upper extremity venous procedures. Character 3 is a root operation. The root operation is bypass. Here the value is 1. Remember, bypass means we are altering the route of passage of the contents of a tubular body part. That is, we are creating a new pathway for blood flow. Character 4 is the body part. In this example, the value is A, which represents a specific vein site being coded, documented here as the brachial vein left. This is where laterality and anatomical specificity show up. Character 5 is the approach. The value is 4, which is percutaneous endoscopic. That matches the word laparoscopic in the procedure statement. This tells us the access was through the skin using an endoscopic device. Character 6 is the device. The device value is 7, meaning it is an autologous tissue substitute. In PCS, we code a device only if it remains in the body at the end of the procedure. Here the graft material remains, so it's coded. For bypass procedures, character 7 is the qualifier. This is critical because it tells the destination of the bypass. In this example, the value is Y, which indicates the bypass is to an upper vein. When we pull all of this together, the full PCS code is 051A47Y. So I want you to start thinking of it as answering 7 specific questions. So, step away from finding the code to there are 7 questions. 7 questions you have to ask yourself when you are looking at a procedure. 7 questions that you have to answer when you're looking at the tables and you're looking at the definition, and that's for every single procedure code. In ICD-10-PCS, Z means not applicable or none. It does not mean unknown. It does not mean unspecified. It simply means that for character position, there is no additional detail to report based on the PCS tables. You're going to see Z most often in the 7th character, which is the qualifier position. Many procedures do not need an additional qualifier, so the table will instruct you to use Z to complete the 7th character code. It's also important to understand that Z can appear in any of the 7 character positions. So you can see Z in any of the 7, right? For example, if no device remains in the body at the end of the procedure, you may see Z in the device position. Or if a table does not use qualifiers, you may see Z in the qualifier position. The key point is that you do not choose Z because you're unsure. It's not an unspecified or not elsewhere classified code. You choose the Z because the PCS table shows you that no value applies for that position. So every time you see a Z in PCS, it should be traceable back to the table as the correct intentional choice. Okay, so now we're going to apply the placeholder concept with a real PCS example. So Dr. McCoy performed a biopsy on Clark's neck. The ICD-10-PCS code to report this would be 0WB6XZX. So 0 is the section, medical and surgical. W is the body system, which for this example is the anatomical regions general. It tells us that it's not a specific organ system, but a general anatomical region category. B is the root operation excision, meaning cutting out or off without replacing a portion of the body part. This fits biopsy because only a sample is removed. 6 is the body part, the neck. X is the approach, which is an external approach. It's performed directly on the outside of the body, so no incision into a body cavity and no scope-assisted internal approach. Z is the device, and it means no device was left in place at the end of the procedure. X is the qualifier, and in this case, it's diagnostic because it's a biopsy, and that is a diagnostic would be in a PCS term. Therefore, you would have an X as the last character of the PCS code. So now we're going to move into the book itself and discuss how the book is set up, how it's organized. PCS feels different, and it feels difficult too because, again, you worked so hard to get through ICD-10-CM last term, and you got used to that structure. And now it's different. Now you're going to see a different layout. You're going to see a more systematic layout. You're going to see tables. You're going to see the core tools as the alphabetic index and the tables. The index will help you with a starting point, okay? Because it starts by procedure type or key term. But the index is never the final answer. So you need to go a lot further. You need to go into the tables. And the tables are where the code is actually built, character by character, based on definitions and options. This section is also where we reinforce the PCS workflow. Start with the documentation, identify the root operation, confirm the body system and the body part, determine the approach, decide whether a device remains, and then check for a qualifier. So the book is structured to support that exact thought process. So in the PCS alphabetic index, terms can be listed in several different ways. First, terms may be listed by the root operation term. This is helpful when you already know the objective of the procedure, like if it's an excision, if it's a resection, dilation, or bypass, and you want to locate the correct coding pathway. Second, terms are listed by body system. This helps when you know the general system involved and you are trying to narrow down the procedure and where it belongs in PCS. Third, terms may be listed by body part. This can help when the documentation is very anatomy focused and you're trying to find procedures commonly performed on a specific site. Finally, PCS also includes common procedure names and eponyms. This means that the record uses a familiar name like a name procedure or common surgical term, you can often find it in the index, and the index will redirect you to the appropriate root operation and table. So we have an example for hysterectomy, common procedure name, but then it cross-references you to the PCS language that you must code with, mainly the root operation and the body system. So we have hysterectomy as the procedure name, but in PCS, it does not code hysterectomy as a standalone term. So the index points you to the correct root operation, which is resection, and then it points you to the correct body system, which is the female reproductive system. That makes sense because a hysterectomy is a removal of the uterus, and when the entire body part is removed, PCS uses that root operation resection. The second example we have here is a Roux-en-Y operation. This is a common procedure name and an eponym that you'll see in documentation. The index lists Roux-en-Y, but then it redirects you to the PCS code bypass, because the purpose of the procedure is to reroute the normal passage through part of the GI tract. It also cross-references you to the appropriate body system tables, such as the gastrointestinal system, or the hepatobiliary system and pancreas. It depends on exactly what structures are involved in the bypass and what exactly was done. These are some examples that you may come across. So here we have the tables. The index helps you find a starting point, but the tables are where the code is actually built and validated. If you are not in the table, you are not finished. PCS tables are organized in a very specific order. First by section, then by body system, then by root operation. That sequence matters because it mirrors how PCS codes are constructed. You identify the section first, then narrow to the correct body system, then choose a root operation that matches the objective to the procedure. Once you are in the correct table, the table provides allowable values for the remaining characters. So we have body part, character 4, the exact anatomical site, the approach, character 5, how the site was accessed, device, character 6, what was left in place, was anything left in place, qualifier, character 7, any additional detail needed to complete the code. What this slide is showing you is that tables are essentially a structured menu. You are selecting one valid option for each character position based on the documentation. The table also controls what is allowed. For example, not every approach is available on every body part, and not every device option is available for every procedure. Appendices in the ICD-10-PCS codebook are not extra material. They are practical tools that make PCS codes faster and more accurate, especially when you're trying to translate real documentation into the correct character value. PCS codes require you to abstract the documentation. And what that means is that you'll read the operative note or the procedure description, and you're going to pull out those objective facts and then match them to the facts in the PCS definition. The root operations, the approach, device, qualifier. The appendices help with that translation step because they provide supporting reference information that clarifies the terms, the definitions, and coding conventions. In other words, when you get stuck, when the documentation uses clinical language that did not clearly match PCS wording, the appendices can help you interpret what you are seeing so you can select the correct value as you build the code. So here we have an example of the appendices for Section C, nuclear medicine, and specifically Character 3, which represents the type of nuclear medicine that is performed. The key point here is that for some PCS sections, the meaning of a character position is very specific to that section. So instead of memorizing these values, you use the appendix as a reference to make sure the correct type is based on what the documentation describes. Now notice how the table lists the PCS value on the left and the definition on the right. The definition is what drives the correct coding. Your job is to match what was done to the closest definition. So, for example, you see distinctions between non-imaging assays, probes, and uptake studies, which involves introducing radioactive material and measuring emissions, but not producing an image set in a way imaging studies do. Planar nuclear medicine imaging produces a single plane imaging display. Tomographic nuclear medicine imaging and PET imaging produces a three-dimensional image with PET specifically involving simultaneous capture of angles 180 degrees apart. Systemic nuclear medicine therapy, which is not diagnostic imaging at all, is the introduction of unsealed radioactive material for treatment. The takeaway is the appendices help you code with precision when the documentation uses terms like PET scan, nuclear uptake, or systemic therapy. Instead of second guessing which PCS value fits, you want to use these definitions to select the correct character value for type. Now we're going to go into general conventions, which is the rules of the road for PCS. How to apply the PCS definitions consistently, and how to avoid common errors when building codes. General conventions are important because PCS is not based on memorizing procedure names. It's based on standard definitions. And these conventions guide how to interpret documentation, so you choose the right root operation, the body part, approach, device, and qualifier. As we go through this section, you'll start seeing repeated themes. Always code to the objective of the procedure. Always confirm values in the tables. And always follow PCS terminology, even when the provider uses everyday language. This is also where you learn how PCS situations like multiple procedures, combined procedures, or documentations that seems vague until you match it to a PCS definition. So, A1 and A2 explain why PCS is so consistent once you understand the structure. A1 is reminding us that every PCS code is 7 characters, and each and every character represents an axis of classification. An axis of classification is simply a category of information. So instead of thinking 7 random characters, we should start thinking it as 7 specific data points. Isn't that interesting? 7 specific data points about the procedure. Now, I don't know about you, but I'm starting to think in metaphors. I'm starting to think, well, not necessarily metaphors, but I'm starting to see kind of a multi-dimensional code take shape. You know, it's like you see holograms, and I'm thinking of a hologram. You know, when there's a multi-dimensional shape. Interesting. A key part of the A1, I digressed, I'm sorry, I have to digress at least once during the lecture, right? A key part of the A1 is consistency with a defined PCS code range. A specific character position always represents the same type of information. The example given is a 5th character represents the approach in certain sections of the PCS. That means when you're coding in these sections, you always know that character 5 answers the question, how did the provider access the site? This is why PCS is more logical than it may seem at first. The meaning comes from the position, and the position is consistent with the code range. A2 builds on that by explaining the value set PCS uses for each axis. In PCS, each character position can use one of 34 possible values. Each character position can range from the numbers 0 through 9 and the alphabet using all of the alphabet except I and O. Remember we talked about that because it looks too much like 1 and 0. So it's eliminated from PCS. That's why PCS codes are alphanumeric, and why you'll never see that I and O. So PCS is structured. It's a structured language. If you're a visual person, you might find that PCS is really easy. You might be very grateful for that visual aspect of the tables. Whereas you may have had more difficulty with CM because you had to really walk through and read. And with the PCS, it's building on that access. It's building based on tables. So if you're visual, this might be really an easy peasy system to learn for you. And if that case, you're going to rock through this course. But it is going to take time. It's a structured language, and each position pulls from a defined set of values. You're going to follow that structure, you're going to follow that code building, and it's going to turn into a repeatable process instead of guesswork. So now we're going to talk about selecting the principal procedure. This matters anytime a patient has more than one procedure during an inpatient stay, which is very, very common. Very rare does a inpatient go in, or does a patient that is inpatient have just one principal procedure. You cannot treat all the procedures as equal. You have to identify which is the principal for reporting and sequencing purposes. In inpatient coding, the principal procedure is generally the procedure that most closely relates to the principal diagnosis and is performed for the definitive treatment, i.e. medical necessity. It is typically the procedure that best explains why the patient required inpatient care. So when you have more than one procedure performed, then you want to know how to sequence the remaining procedures appropriately. You base that decision on the relationship to the principal diagnosis and whether the procedure represents definitive treatment versus a diagnosis or supportive services. And here's how you want to apply that guidance on the slide. Definitive treatment performed for both the principal diagnosis and secondary diagnosis. When the provider performs a definitive treatment procedures for more than one condition, you sequence as a principal procedure the procedure that is most directly related to the principal diagnosis. Definitive treatment and diagnostic procedures performed for both the principal diagnosis and secondary diagnosis. When you have a mix of treatment and diagnostics, you still sequence as a principal procedures and the procedure that represents definitive treatment and is mostly related to the principal diagnosis. That practical takeaway is straightforward when you're deciding the principal procedure. You do not want to default to the biggest procedure or the first one listed. You want to anchor your decision to the principal diagnosis and prioritize the procedure that provides definitive treatment for that condition. Diagnostic procedure for the principal diagnosis and definitive treatment for a secondary diagnosis. When you have this situation, the principal diagnosis is still the anchor. Even though the treatment procedure may seem more significant Clinically, the guideline says that you sequence a diagnostic procedure as a principal procedure because it is the procedure most related to the principal diagnosis, and that relationship takes precedence. So the decision rule is if only the procedure is tied to the principal diagnosis and it's diagnostic, the treatment was done for something secondary. The diagnostic procedure becomes the principal diagnosis. And for no procedures are performed that are related to the principal diagnosis. Sometimes this happens when the principal diagnosis is managed medically, it's monitored or evaluated without a reportable procedure, but procedures are performed for secondary conditions. In that case, you sequence the procedure performed for definitive treatment of the secondary diagnosis as the principal procedure, because there are no procedures, definitive or non-definitive, related to the principal diagnosis. The key takeaway from these rules is that the principal procedure selection is not about the largest or the most invasive. It's about applying the guideline logic in a consistent order. First, look for procedures tied to the principal diagnosis. Then decide whether those are definitive or diagnostic. And only if nothing is related to the principal diagnosis do you move to the definitive treatment or to the secondary diagnosis. So we've reached the end of our lecture, almost an hour's worth. There was a lot to cover. The main goal with ICD-10-PCS is to give you a clear, beginning, friendly overview so you know what it is, where it is used, what makes it so different from other code sets, from ICD-10-CM, even from CPT, which we're yet to get into in the spring. The chapter was designed to hopefully lower your anxiety just a notch, because you want to think of PCS as this. You want to think of it as predictable and learnable, step by step. And don't take it all in one setting, right? Because it can get overwhelming. Just as you learn, think back of ICD-10-CM and learning those first few weeks and how overwhelming it felt. This is step by step. It's more methodical. It's more data driven. It has points to it. You have an access. You have those tables that are formatted and constructed, and you go throughout the chapters learning about of course you apply those coding guidelines, but they're not as much of a compass as PCS. As we saw in CM, as we do see as PCS used in PCS, we see it more in CM. But what we see in PCS are the tables. And the tables and those 7 characters, remember the number 7, and 7 questions that you have to answer for each time you want to code a procedure. So with that, let me know if you have any questions. I'm super excited that you decided to join me for the winter term. I am going to work really hard at making it exciting for you and have it more interactive. As well as if you need to reach out to me, please email or set up a time during my office hours. So I will talk to you next week. Take care. Have a great week. Bye-bye.